Hello, and thank you for the opportunity to speak at Pedirhythm. I've been asked to talk about resynchronization of systemic RVs and single ventricles. My attempt at humor was better in the in-person session, but for those of you who were there, you'll know that I was in a session that included Dr. Henry Chubb and Dr. Jan Janasek talking about conduction system pacing and subpulmonary RV pacing, respectively. Both of them had great talks. You should definitely refer to them online as well, with a lot of data published as to the utility of conduction system pacing and subpulmonary RV pacing. So during the session, it definitely left me feel like the odd person out. During it, getting the topic of systemic RVs and single Vs, just because they're not as robust as Henry and Jan's talks were. But just to go over the data that we do have, we know that CRT can work well for biventricular heart, especially if you have a systemic left ventricle. A little less optimistic about single ventricles, and systemic right ventricles overall had a relatively less robust or poor response to CRT. Ted O'Leary recently published more up-to-date data on our single ventricle experience here in Boston, and showed that, at least compared to single site pacing, CRT is okay. Helps preserve your function at the time rather than make it deteriorate, as single site pacing can do. And then in 5-year follow-up, trended towards better outcomes with those with CRT having less death or transplant. Henry has provided more robust data and newer data on this, which he presented in abstract form at Pedirhythm and also in this poster here. So please look forward to that when it's published in a manuscript. But just getting back to Ted's paper, stated that to help with CRT, more exact techniques for lead positioning need to be developed, and a more personalized patient-specific approach may help. Someone who's demonstrated that well is Jeremy Moore, who looked at his experience with systemic RVs. Here are 6 patients, and they mapped the best spot for pacing the systemic RV. Found that was usually on the basolateral right ventricle or the RV outflow tract. For this group, the QRS decreased on average 50 milliseconds, with the functional improvement in half of them. Unfortunately, as you know, a lot of these patients require epicardial leads, just because transvenous leads are often limited by baffles getting in the way or coronary sinuses that don't really get to where you want them to go. Jeremy also published a multi-center report on CCTGA. This was a great study showing where the conduction system is in these patients, and it showed that implanting a lead in that location can be successful in the majority of patients. There were 15 in total, 13 successful implants with a better QRS afterwards and a functional improvement of 5. I'm pretty excited about this because I think this conduction system pacing may be the way to go for this difficult population. See how this progresses in the future. But what about single ventricles? Here is a 3-year-old with a right dominant AV canal, has Ebstein's malformation of the tricuspid valve, palliated to a lateral tunnel fontan, and had poor function afterwards, as you can see here. This was in the setting of a wide QRS and the right bundle branch block. Here you can see the strain imaging showing that somewhat desynchronous contraction of the single ventricle. So we took a more personalized approach, if you will, to this patient, brought him to the operating room, and then mapped along the surface of the heart and found the earliest area of activation on the posterior aspect of the single RV and the latest activation on the anterior aspect of the single RV, and then paced from both sides. You can see achieved a pretty narrow QRS complex. And you can see on the strain imaging here that the segments seem to contract in a more synchronous fashion. More importantly, here's their function on the left, pre-CRT. severe RV dysfunction, and then after a year, on the right, a strong moderate dysfunction afterwards. So improved, not perfect, but did improve. Same thing here for short axis imaging. On the left was pre, and then on the right is post. Perhaps more dramatic and maybe more important was the patient's response in terms of their BNP. Here you can see it was when CRT was initiated. Fortunately, this patient was their own case control trial, where one of the leads stopped capturing, and you see the BNP got worse. But then when the output was increased, their BNP plummeted pretty dramatically. Same thing for the patient's weight. CRT initiated here, and then when it was fixed and optimized, you can see their weight improve. Unfortunately, as with most epicardial devices, their leads started to have some more wear and tear on them relatively quickly. But thankfully, thanks to insights, including the data from Dr. Janasek, we were still able to pace this patient adequately, which you can see here. The atrial lead failed. The posterior RV lead in blue had a very high output, but could still sense. And then the anterior RV lead in green here had a somewhat higher output, but still not too bad. So we were able to set the patient VVI and had them trigger off or sense off their posterior RV lead and then pace their anterior RV lead. And with this, we can maintain the patient's narrow QRS, and you can see their function here stayed within the moderate range, maybe a little better if you squint. Here's another example. Here's a 2-year-old with a single right ventricle and aortic atresia, had a stage 1 sono, and then went for a bidirectional Glenn, and then unfortunately developed a dilated RV with moderate dysfunction, as you can see here. This is one of the examples where I've come to love CT and MRI, not only because of the group of individuals that I get to work with, but also the amazing imaging that they can provide and help with our patient care. Here is my low-tech way of telling the surgeons where to put the leads. We look at the MRI and find the earliest and latest areas of activation mechanically, and then ask them to aim for that spot in the operating room. We're also mapping electrically as well while you're in there. But it also helps give them landmarks as to where to go and become a little bit more targeted in their approach. So we can tell them where the lead or where we desire the lead in relation to the sternum and the surrounding ribs. So for this patient, we found the earliest latest activation. This we prefer not to go posterior. In this case, we decided just to focus on the atrial lead and the anterior RV lead, and place that lead in this location here and fuse it with their intrinsic conduction. Here you can see them unpaced with the right bundle branch block. And then here it is fusing with their intrinsic conduction with the narrower QRS and more right bundle. Looking at their BNP curve, here's when they started pharmacological therapy with the help of our heart failure team. And then here's when their CRT was initiated and their BNP improved. Recently published our data on these patients with the right bundle branch block in JACC-EP. And have since then done a handful more patients, including those with Epstein's, DORV, and right dominant AV canals. And then all those patients, we were able to take their function and narrow down their QRS and improve their function at the same time. And how about left ventricles? I worked hard on this slide and it's not working, unfortunately. Beyonce letting me down. So LVs with right bundle branch blocks tend to be focused on the left ventricle in the past, putting leads anterior, posterior, similar to the x-rays here. The question was, learning what we know about fusing with right bundles, should we focus on the RV, put a lead on the latest RV activation, and then fuse with conduction? So as an example, here's a patient with small left-sided structures, bicuspid aortic valve, large VSD and coarc. At 5 months of age, had a PA band and coarc repair, then had sub-AS obstruction and a tight PA band, along with severe LV dysfunction afterwards. So 20 months of age, had relief of the sub-AS and loosening of the PA band. Unfortunately, still had severe LV dysfunction. Here, as you can see, the patient's EKG, decent right bundle branch block for someone at this age. So we also took this patient to the OR, mapped them electrically in terms of the earliest and latest activation on their ventricles, and then fused it with their intrinsic conduction. And here you can see their EKG afterwards, much more narrow QRS, no more right bundle branch block. And here is their echo. On the left side is pre-resync, and on the right side, afterwards, you can see beforehand, poor function, more dysynchronous contraction between the two ventricles, and then better function. This was just a week afterwards. Perhaps a little bit easier to see in the short axis, you can see sort of discordant contraction between the right and left sides. And then after a week of resync, much better synchrony and function overall. And what about patients with complete heart block rather than a right bundle branch block? I think they're a little bit different. Here's a 3-year-old LTGA double in the left ventricle, had a PA band, and then a bidirectional Glenn at 5 months of age. Unfortunately, had complete heart block and had a pacemaker implanted with leads on the LV apex and the LV base. Came to us with bad ventricular function. The surgeon repaired both AV valves, enlarged global ventricular foramen, and then placed new epicardial leads. We did an MRI ahead of time, and you can see where we found where the earliest and latest activation was mechanically, and then had the surgeon put one on the diaphragmatic surface and then one sort of on the rudimentary right ventricle. Here's the chest X-ray showing that, again, with the unipolar screw-in lead on the rudimentary RV sort of right across from the enlarged global ventricular foramen. Here's their echocardiogram a year later. They did okay. You know, their LVDV came down. Their EF improved from 24 to 34%, but not as strong as a response as I was hoping for. And the question is whether or not we should have just treated this as a basic left ventricle, aim sort of anterior posterior, sandwich that left ventricle with the leads, rather than aiming for that rudimentary right ventricle. How about a patient with a left ventricle and a left bundle branch block? So here's a 7-year-old DTGA double inlet left. Had a DKS in the Glenn at 6 months of age, had a BIV repair at 5 years of age, and then came back to us 7 months later. And here you can see their function has gone down pretty dramatically. Also had fatigue, feeding issues, and swelling. And this is all in the setting of a left bundle branch block, as you can see from the EKG there. This is interesting. You know, I apologize. This is my low-tech way of getting this image onto this PowerPoint slide, but this patient had an MRI pre and post surgery, and you can see on the bottom part of the screen with no left bundle, heart beats synchronously, and good function. But after surgery, in the setting of a left bundle branch block, you can see discordant contraction between the right and left ventricle. And then you can see the blood pool just really sloshing back and forth in there. So it's really acting like an energy sink. And so we thought, because of that MRI appearance, maybe if we just improved synchrony overall, we can help this patient's function. So we ended up putting the leads on the right ventricle, as you can see here, in the green, and then on the left ventricle in the red, using the MRI to help us look for mechanical activation, and then in the OR, looking at electrical activation. You can see with pacing from both leads, here's the EKG, a little bit narrower QRS, and then trying to fuse with intrinsic conduction. This was the best sort of EKG that I could get. And so their BNP told a good story and a lesson that I learned. Here you can see with BIV pacing. So again, pacing from both leads, their BNP came down. And then when I thought that fusing with their left bundle actually maybe gave a slightly better QRS at the time, you can see their BNP trended back up. One of our former fellows, Omar Meziad, who now helps take care of this patient, also pointed this out to me recently. You can look at the optical tracing, and here's when I tried to fuse with their intrinsic conduction definitely caused an increase in their optimal tracing. And then here's when IV pacing was started back up again. Overall, pretty dramatic response. We've also been doing pressure volume loops in the cath lab and using a conductance catheter and looking at various conditions with our resync patients. Don't ask me to explain everything behind this, but my basic look is that the area inside the curves is the stroke work, how much the ventricle is working to eject blood. The yellow here is the baseline condition of left bundle branch block. The white loop, which is the best one, largest area, so best stroke work, is when you IV pace, and all the other colors are trying to fuse with intrinsic left bundle branch block. So with IV pacing, you can see the function looked much better. This on the left again is pre, and on the right with IV pacing, overall improved left ventricular function. So it makes me think that maybe we should just kind of keep it simple. And for patients who have a left ventricle and either complete heart block or left bundle, we should really just treat the left ventricle like a sandwich, really sort of sandwich that ventricle anterior posterior. But those with right bundle branch blocks, we should be thinking about it a little bit. All right, so other lessons that I've learned through all this is that, I hesitate to bring this up, especially during the session when Dr. Janasek was looking right at me, but I think I'm becoming a little less enamored with LV apical pacing, although it's proven to work well in those with congenital heart block with normal hearts. Even Dr. Janasek's group is starting to report that this might not be ideal with those with congenital defects, heart defects. So they looked at 3 patients in this case series, one with triatresia, one with a tumor, and then either mitral valve replacement, and one with tricuspid stenosis as both gland, and found that apical pacing was not great with EFs trending down to the 20s and 40s. But when you upgraded them to a traditional CRT system, their function improved. And part of this apical pacing that might not be great for patients is this early stretch or bulging out of the basal LV while the apex is squeezing. We've seen this ourselves in Boston. Here's a 5-year-old heterotaxy left dominant AV canal who had a Fontan and then a BIV conversion. Here are the leads on the anterior LV apex, and you can see there's this longitudinal dysynchrony here when pacing from this site. We then ended up putting in a posterior RV lead, so giving them a more traditional CRT system, and then 6 months later, better function overall, much less dysynchrony as well. So how about LV apical pacing in the setting of IV pacing, meaning rather than a posterior LV lead, you have an LV apical lead? I think the same issue applies. Here's somebody who has LTGA, VSD, pulmonary atresia, had a gland and then a BIV repair, had a lead put on the anterior LV and then another on the RV apex. A little bit different, but still apical pacing. Here's their EKG. And then here, again, my low-tech way of getting CTs onto the screen. You can see pretty desynchronous contraction when pacing from the apex. This kind of peristaltic contraction of the left ventricle from apex to base, which brought the patient's function down. Now for epicardial leads, obviously there's a lot of challenges that come from putting it in the right position and getting the location that we need. A lot of this is working with the surgeon, and we often can ask them for a posterior lead, but given issues in the operating room, sometimes they end up too apical, and then sometimes they end up too much on the diaphragm. Not really hard to understand. It's really difficult to get a lead posterior via sternotomy. It's a lot to ask the surgeon after complex surgery to kind of focus on putting a posterior lead on the heart. And so sometimes I wonder, maybe to help optimize our patients down the road, we really should have them put in a standard dual chamber system and then come back later and place a posterior lead at a different time. Now, you've probably noticed that I haven't talked about systemic RVs in a while. Part of that is just because I really don't know how best to pace the right ventricle. I used to think we weren't very good at it, but this paper here shows that maybe I'm wrong. Here's 85 patients, 31 with systemic RVs, median age of 44 years. Found that for systemic RVs, they actually 80% of them actually responded to CRT, which was statistically not different, but numerically even better than the systemic left ventricles. Overall, their QRSs decreased, their EFs improved, and their overall outcomes in terms of mortality or transplant were also similar to those with systemic left ventricle. Importantly, at 1 year, their functional class improved to 1 or 2 in 80% of patients. They did note that patients who were female, those with a narrow paced QRS, and those who's had a higher baseline EF responded more to CRT. So it's better to start resynchronizing them early when your EF is 40 versus 30%. What they also noted, which was interesting, was that they didn't actually say anything specific about how they placed the leads. It was left at the discretion of the operators at each different center. They just maximized the difference between the LVs and RVs and didn't really do any systematic mapping electrically or mechanically. So maybe the KISS principle here, keeping it simple, might apply for RVs, although I still think there's a bit to learn about this patient population. All right, finally, my last few minutes, just talking about conduction system pacing for single ventricles. As you know, this will obviously then require us to put leads in the systemic circulation. And the question is, I'm ready for that. Here's a patient where we did this, where we went across the Fontan baffle and placed the lead near the apex of the single V. We knew this patient was going to get transplanted, so we knew it was only for a short period of time, but we did do annual CTs and echoes on them for 2 years. And they had no evidence of a thrombus. They were already on warfarin for their aortic valve. Iqbal Al-Assad recently published the experience on putting leads within Fontan baffles, looked at those without leads and those with epicardial leads and then transvenous leads, and found that having transvenous leads did not lead to a statistically important increase in clot formation. Importantly, she did note that if you used antiplatelets or anticoagulation, you decreased your clot risk overall threefold. How about leads in the ventricle? A little less reassuring here. A lot of the data is from adults doing endocardial LV pace. Here's 138 patients. Of those, 9 patients had 14 TIAs, and 5 of them had strokes. This gave an overall event rate of 2.6 per 100 patient years, relatively high. They did note, however, that in those that did have events, the INR, when it was available, was subtherapeutic. This isn't too dissimilar from a paper from Dr. Carey. It's an older study, but a nice one that I think we're all familiar with. Looked at patients with residual shunts and then compared those with or without leads, and found that transvenous leads were an independent risk factor for a thromboembolic event. They too noted that it happened while you're on aspirin or warfarin, but also noted that in those where the INR was available, it was either subtherapeutic or unknown. So I think transvenous leads in the atrium for Fontans or within the Fontan baffle are safe, but endocardial leads maybe not as safe, but definitely something that we should be thinking about more in this difficult to resynchronize population. And of course, for conduction system pacing, one of the other issues is that not a lot of them have quote central heart blocks, so in the his or proximal bundle branches, but rather have more peripheral heart block due to their surgical repairs. There is growing evidence as to the utility of HIS optimized CRT, so putting a lead in the HIS or the more centrally around the bundle branch blocks, and then placing another lead more peripherally. I think with a name like hot CRT, it's definitely something that we should consider doing more to help our patient population. So I think we're just at the tip of the iceberg as usual in pediatrics congenital heart disease. But you know, there's a lot to learn about CRT. I think there's been more more and more talk and evidence about the utility of bilateral bundle branch placing, which would be exciting to explore in our patient population as well. So in summary, resynchronization of systemic RVs and single ventricles remains challenging. This data gives us hope for good and improving outcomes. Each patient is unique and requires a personalized approach as to how we attack their heart disease and their type of heart block. Maybe we should start considering putting leads in the systemic circulation. Definitely up for conversation about it. Of course, and there's still a lot to learn and more challenges ahead, but I think as a group, we're all willing and eager to take this on. Thank you very much.